Okay, what we're going to do on this hour is hope you're having a good day. The next discussion is on the organ effects on inhalational agents. The first thing we need to discuss is the hepatic effects of many of these agents. Hepatic blood flow is affected by all the agents. What you see with isoflurane, sevoflurane, desflurane is that your total hepatic blood flow remains unchanged. This is partly due to the hepatic artery blood flow is unchanged, but the portal vein blood flow actually increases. So these agents, such as iso, sevo, and desflurane, are actually vasodilators. On the other hand, if you look at halothane will actually have a overall decreased hepatic blood flow on all your patients because it acts as a vasoconstrictor. This has a significant effect of increasing hepatotoxicity in the population you're dealing with in this kind of case. The other thing that the agents do is that they'll alter drug clearance. There's a decreased clearance possibly due to anesthetic enzyme suppression, not to the actual effects on total blood flow. Where that may be actually slightly different, maybe halothane, but as we'll see in a little bit, halothane hepatitis is actually an immune-mediated reaction. The liver function test we see with all agents that you used to use is that you see a small elevation, and this is not completely found to be due to the actual anesthetic agents, but may actually be due to surgical stress as well. The biggest hepatotoxicity risk is when you use the agent halothane, and there's also a significant increased risk when patients are cirrhotic or already have abnormal architectural damage to the liver. It appears that hypothermia may be a little bit protective of patients which are receiving multiple anesthetics to their hepatotoxicity. Now, there's two types of halothane hepatotoxicity. The first one is a self-mediated post-operative hepatotoxicity. That's due to that. Okay? About 20% of patients that are receiving halothane will develop hepatotoxicity like this. Usually it's related to the decrease in blood flow that you see associated with halothane, and this leads to nausea, lethargy, fever, and a mild elevation in your liver and transaminases. People don't die from this self-limited problem. On the other hand, you may actually develop halothane hepatitis, which is rare, thank goodness, but occurs in about 1 in 10,000, 1 in 30,000 cases of use. And there's been reported cases of repeated dosages of halothane B showing that it increases the risk. Even if the halothane had been given 13 years before, on re-exposure, that individual may get this fulminant hepatitis that you'll see. We see that adults have a much higher risk, and I'll show you the risk factors in a minute, and children seem to be a little bit more protected from this disease process. What you end up seeing with halothane hepatitis is you get a massive central lobular hepatic necrosis and subsequent death in those individuals. We know it's an immune-mediated reaction, not just a metabolism problem. What the risk factors of halothane hepatitis is a prior exposure to halothane. Like I said to you before, it could be several years beforehand, or it could be recent. People that have most risk of this is people that are women, usually that are morbidly obese, middle-aged, and may also have increasing genetic susceptibility. The symptoms that are seen when the patient develops halothane hepatitis is a dramatic increase in eosinophil levels, leading to eosinophilia, fever, rash, and arthralgia as this immune complex mediated reaction. The mechanism is basically it's an IgG antibody reaction to liver microsomal proteins on the surface of the hepatocyte. What happens is when the metabolism of halothane takes place, it forms a neoantigen called trifluoroacetylation, or TFA, which forms on the surface of the cell and identifies it to the body as being something possibly foreign. As a consequence, the IgG molecule binds to that site and attacks individual liver cells, killing them, and as a consequence, causing massive hepatic necrosis. Other volatile anesthetic agents may also have an increase of formation of TFA, which also may cause this autoimmune reaction to develop. Specifically, enflurane has the highest risk because it has most metabolism. Halothane is the most metabolism, followed by the least being isoflurane, and the least being that is desflurane beyond that. But if you have prior exposure to hepatitis from halothane, that person developed halothane hepatitis and survived, it might be prudent to stay away from these agents as the metabolism takes place. You'll see the metabolism via the cytochrome P450 E1 system, and the intermediate trifluoroacetyl metabolite is actually formed as a byproduct of that metabolism. So that may actually induce that hepatotoxicity that you may see. These, remember, these agents are methyl ethyl esters, and but do have a little less metabolism, but still don't have zero production of TFA. SIBO, on the other hand, may actually be safe to use for patients that are sensitized to halothane, isoflurane, enflurane, or desflurane, because the metabolism is through what's called a hexafluoroisopropanol intermediary, which is an aldehyde from an inorganic fluoride, and it does not lead to the formation of hapten, which is the TFA. Volatile anesthetics and renal effects. What you see is, as you saw in a prior lecture about cardiac output, as cardiac output decreases and blood pressure diminishes, you'll see a decrease in renal blood flow. This leads to a decrease in GFR and decreased urine output. This can be partly reversed by properly prehydrating the patient, if at all possible. The other thing that happens besides just a decrease in cardiac output is that you have fluoride-induced toxicity from some of the volatile anesthetics. Enflurane specifically, and sevoflurane being the next, and sevoflurane may be significantly overhyped as to the nephrotoxic levels of its effect. What we do know is that vinyl halide nephrotoxicity, which is a combination of a strong base, which usually is found in a CO2 absorber that's been dehydrated. The strong base that's inside the CO2 absorber is there to activate and make the CO2 absorption take place more rapidly. So if you don't have adequate levels of hydration in your CO2 absorber, the strong base becomes more potent, and as consequently breaks down the compound, such as sevoflurane, very rapidly into a formation of what's called compound A. Now, compound A itself is nephrotoxic at certain levels, but if you can maintain the levels high enough of flow through and prevent the formation of high enough levels of compound A, you don't have that effect and don't have a problem. What's still recommended when you look at the paperwork is that it's still recommending flow rates of over 2 liters per minute. If you look at the paper from prior of Binot, he used a combination of SIBO plus nitrous oxide, and he never got to the toxic ranges of this drug most of the time, so he never saw any compound A toxicity. And he was able to go down the levels below the accepted 2 liters per minute. That simply has to do with he never got to high levels of compound A. So be careful with that. Don't just go to low levels of low flow rates and not worry about it. In that situation, you may actually have enough compound being formed to cause nephrotoxicity. What about the obstetrical effects of these drugs? Volatile anesthetics all decrease uterine blood flow, but of more concern is that they decrease uterine muscle contraction. And this can risk postoperative uterine atony and increase the risk of developing significant postoperative bleeding. What we do know is that if you keep the MAC value of the volatile anesthetic less than 0.5 or by 0.5 MAC, then you have very little effect at all on the uterine tone. So it's a good idea to combine your two agents, such as nitrous oxide and your volatile anesthetic in this situation, to make sure that you don't have the uterine problem of uterine atony. Some people get concerned about nitrous oxide possibly getting to the baby. That's a possibility, yes, but you're offsetting the risk to the mother, who may then postoperatively hemorrhage because you're not using the nitrous oxide. So for that reason, I would still recommend that you use nitrous oxide in combination with your volatile agent during these procedures. Remember, the nitrous oxide has no effect on uterine tone at all, so in that sense it's beneficial and protective to the mother. As for genetic effects, most of the volatile anesthetics have not really been found immunogenic. What they are been told is that nitrous oxide at certain points of pregnancy may actually cause an increased risk of miscarriage, which may be the case. So Nitrous oxide in a pregnant woman may not be the wisest choice to use after the baby has been, before the baby has been fully developed. But once the baby is fully developed, the use of nitrous oxide has really not been found to be a problem. What you see is that nitrous oxide has been possibly, people have been concerned about over the years about increasing the risk of women working in the operating room. That's really not been found to be the case, especially with the use of scavenging systems. So that's something I wouldn't be worried about. What about nitrous oxide and B12 deficiency? Well, that is a big issue. Nitrous oxide metabolizes a cobalt core in vitamin B12. This forms an activated, it's called methylcobalamin. And methylcobalamin is important for the conversion of homocysteine. As a consequence, you get a tremendous increase in homocysteine levels when you're giving people nitrous oxide that have B12 deficiencies. So homocysteine levels that's elevated already is an indicator of B12 deficiency. Eventually, if you don't develop, if you don't allow the reaction to go forward, you will actually begin to affect production of serotonin, norepinephrine, as well as dopamine. The other thing that can also affect is the myelin production, and you get a demyelination disease process. Usually that happens with prolonged exposure to this agent. Where also may be an increased risk of developing complications is that patients that already have vitamin B12 deficiency will develop what's called a macrocytic pernicious anemia, and those people should be really not be given nitrous oxide, or at least not until you treat them with B12 first. Who's also at significant increased risk is patients that have HIV, patients over the age of 65, patients with multi-infarct dementia may be also a concern. This is the natural pathway for DNA synthesis, for your purine synthesis, as well as the formation of a thing called S-adenosylmethionine. What you see down here in the methylcobalamin is what is the agent that's going to be affected by nitrous oxide exposure in somebody who has vitamin B12 deficiency. So what you'll see first is you'll see the X mark in the spot where the methylcobalamin is going to be inhibited. As a consequence, you'll see an increase in homocysteine levels and also 5-methyl tetrahydrofolate levels. The homocysteine levels is what we tend to measure, so that's what we usually indicate to us that we have vitamin B12 deficiency or toxicity induced by nitrous oxide. As a consequence to the lack of formation of tetrahydrofolate or methionine, you'll start seeing a depletion in these levels. As a consequence, you'll see a decrease in purine synthesis, which begins to affect your DNA. You see here, then you keep going, and you see the effects is it'll inhibit the formation of serotonin and myelin production, and eventually your purine synthesis. What eventually will happen is your UDP levels begin to increase, and your RNA production will increase as a consequence. And this will lead to protein synthesis that's uninterrupted in these individuals, but still with not adequate levels of hemoglobin. And as a consequence, you develop what's called a hypochromic macrocytic anemia. Now, what leads to demyelination is the D-methylmalonyl-CoA is going to be inhibited by the conversion of adenosylcobalamin. Is going to be attacked by the nitrous oxide. See right there, and as a consequence, you will see an elevation of L-methylmalonyl-CoA because it can't form succinyl-CoA. This will increase the D-methylmalonyl-CoA and eventually increase your methylmalonic acid, which is what actually causes toxicity to the myelin sheath. Nitrous oxide and B12 deficiency is, if you're chronically exposed to this, you'll get paresthesias and poor manual dexterity 1 to 3 months after nitrous oxide exposure. Onset is often with sensation of coldness, numbness or tightness in the tips of the toes and the fingertips. Sometimes it will involve arms and legs, is uncommon, and onset of the arms is even rare. Paresthesias are usually ascending, involving the trunk, leading to a sensation of constriction of the abdomen and chest. And untreated patients may actually develop limb weakness and ataxia. Metabolism of these medications is halothane is a monotonically metabolized drug, about 15-20%. Goes both through oxidative and reductive mechanisms. Most modern anesthetics have minimally metabolized, which is a good thing. But what determines your metabolism is a chemical structure, hepatic enzyme activity, blood concentration of anesthetics, and the genetic factors. Now, there's some recent problems that we've seen with CO2 absorbers. CO2 absorbers combined with volatile anesthetics, especially if they're dry, is that they'll form carbon monoxide. All of them will do that. Sevoflurane is unique in the sense that it converts its metabolism in by the strong base into formation of compound A. And also has been found recently to also may possibly increase the risk of developing cancer fire. If you see in this example here, this is a typical CO2 absorber device. Inside the top layer is where the gas is initially coming in. This is actually turning purple, which indicates to you this portion of the CO2 absorber is now consumed and no longer will be effective in removing CO2 out of the system. The downside to that is it depends on the water vapor pressure that's inside the system. It has to be wet for the dye to work properly. So if you're having a dry barrel line or a dry CO2 absorber, this purple color will convert back to its white initial appearance. So what happens if, how do you get into a situation where you get desiccation taking place? Remember that 15% of weight of the actual canister is water. So you're not going to just measure the weight, which you could do, but most people are just not going to do that. If you're going to take it out, you're going to replace it. But what can actually increase the risk of desiccation is let's say late at night you're finishing up a case and you leave your oxygen flow rates at 10 liters per minute because you forget to shut them off because you extubate the patient. Now you come back and you put on your circuit, and when you apply your circuit, you don't just leave the circuit open, but rather you put a mask at the end of it. Well, the mask has an actual bag on it, and that bag now prevents the gas flow from going out into the environment. Instead, it's to recirculate back into the CO2 absorber. And what really makes it the final fatal flaw in this situation is that instead of putting the bag at the end, which would allow recirculation taking place, and we maintain the hydration, is that you leave the bag off the system. As a consequence now, you'll see the following. The gas will be pushing out the water vapor pressure, the CO2 absorber, and it'll be going out through the actual ambu bag site, the bag where it should be connected. So as a consequence, you'll get dehydration, desiccation taking place in the CO2 absorber. Now, CO2 absorbers, all volatile anesthetics, you combine them with a strong base, and unfortunately we use strong bases because they add to the capacity of the CO2 absorber to work properly, that they'll convert by metabolism, convert and form carbon monoxide. So how do we detect that in the operating room? Unfortunately, we don't have any carbon monoxide monitors on our machines, but that's not why. And if you think that you can pick it up by looking at the absorber color, that's the reverse, because the absorber, as it dehydrates, the color goes away. You also may also see a decrease in pulse oximetry. It's going to be mild. The person's going to have that red tongue, which is a typical carbon monoxide poisoning. The only true way to diagnose this problem is you have to think about it as check your carbon monoxide levels by blood gas. The other thing that will also be helpful is if you're using desflurane, isoflurane, or enflurane. If you have a mixed analyzer during the case, what you'll see is, especially if you're using desflurane, that the machine will start saying that it's measuring enflurane. The reason it's measuring enflurane is one of the additional byproducts of metabolism. It's a conversion of something called trifluoromethane and trifluoromethane to a mass spec or a spectrometer. Looks like enflurane, so it begins to give you this mixed read. If you're seeing that, that patient really is most likely getting some kind of metabolism taking place in the CO2 absorber, and you should change it out. And I would recommend you do that immediately as soon as possible. If you're using sevoflurane and you're still having this kind of reaction formation taking place, Unfortunately, you're not going to get this formation of trifluoromethane, so you won't get warned ahead of time. That's the downside of using sevoflurane. One of the things that people are now recommending is that if you are going to use a lot of sevoflurane, is that you need to consider possibility of airway fire with this agent. You may want to consider putting a temperature probe on the absorber, which I'll show you in a picture in a minute. And treatment basically is to change out the CO2 absorber anytime you think that this person has an increased risk. This is the picture of the new study showing measurements of temperature inside the CO2 absorber. This is to rule out a secondary reaction from sevoflurane from a desiccated absorber. I'll show you that in a minute. Effects of carbon monoxide is that they significantly impair oxygen delivery. Remember, they poison the hemoglobin. Patient may also complain postoperatively of chest pain, and you may also get delayed neurophysiologic effects 3 to 21 days afterwards, including cognitive defects, personality changes, and gait disturbance. One of the things that you want to make sure of if you think that a person has carbon monoxide poisoning is draw blood gas and put this person on 100% oxygen and until the carbon monoxide levels fall to normal levels. One of the things that's increasingly since 2003 is Barreline was taken offline because of this. Barreline used to be the main source of CO2 absorbers in the United States, but when you mix it with sevoflurane in a dry CO2 absorber, which is Barreline, it'll convert sevo into methanol and formaldehyde, and also a byproduct will be a tremendous amount of heat. The consequence of that means you see a decrease in sevoflurane in your consumption rate on your analyzer. So that would indicate that the medication is being consumed somewhere, and that's where it's being consumed is in the Barreline itself. The actual reaction increases dramatically and produces a tremendous amount of heat, and it can actually generate up as much as 300 degrees Celsius in temperature heat, and as a consequence of combustively, spontaneously combust and cause an airway fire in that individual, which has been reported. The other thing that has been reported is that formaldehyde is also significantly pulmonary toxic, so another thing you've got to be aware of. So sevoflurane, be very, very cautious about having a dry, desiccated CO2 absorber with this drug combined. And start going on and discuss further xenon. Xenon is a noble gas that occurs in the natural environment. It's usually in very, very small concentrations and usually has no effects on humans as a consequence. But once you get it enough concentration, it acts as a very good anesthetic. The good thing about xenon is that when you redistribute it back into the environment, it just gets redistributed out in the atmosphere and doesn't have any toxic effects or bad effects to the actual troposphere, and doesn't affect any way of the atmosphere at all, versus the volatile anesthetics will attack the troposphere and possibly is a consideration in your carbon dioxide problem in the world. That's a concern, but I don't know, we'll see. But anyway, xenon is one of those beneficial agents that you don't have to worry about it. Now, xenon is being used in Europe right now, and it's not really been available in the United States just yet. It has a very small blood gas partition coefficient of 0.115, which makes this agent very insoluble, which is an ideal anesthetic agent in the sense that it has very rapid onset and very rapid offset. One of the downsides to this agent is that if you stop delivering the xenon to the patient in very short order, the patient will be wide awake, which may not be the most beneficial things at times. The oil gas partition coefficient is actually fairly low, which indicates that its MAC equivalency is pretty high. Percentage-wise, if you look at the 1 MAC value of xenon, it ranges between 63 to 71%, which makes it available to maximum you can really give somebody is around 1 MAC of this agent, because the other 30% is going to be oxygen. The MAC awake is actually fairly low. The person can wake up at 33% with this agent, so it doesn't give you much margin of safety between being awake and being asleep. It seems like it's gender specific, and which is kind of rare for most volatile anesthetics. It seems like the MAC is a little bit lower in females. This is a picture of the xenon anesthesia machine It's very different than the other machines because it's a much tighter system. You're able to go to low flow systems in this machine and to go very, very low flows, which saves you a lot of money on the xenon gas. One of the significant issues with xenon is that you got to pre-oxygenate the patient fully before you start using it. Xenon is a non-pungent, noble gas and can go into airspace. It doesn't go in as quickly as nitrous oxide, but it still can increase the risk of developing pneumothorax or developing tension pneumothorax if somebody already has a pneumothorax. The good thing is it's not harmful to the environment. Xenon is an exit amnestic. It's a fairly good analgesic. It is not a very good areflexic, which means that you have to add muscle relaxant when you use this agent because it has minimal or no effects. If you want to let somebody spontaneously breathe, xenon is actually a very good agent because it doesn't affect ventilation that much. As for the autonomics, it's the most supportive of all the agents, and nausea, vomiting is still unsettled if it increases risk or not. Xenon, in many ways, is an ideal anesthetic agent. These include that it's non-flammable, it's non-explosive, it has a very rapid induction and emergence due to its very low blood gas partition coefficient of 0.12, which is the lowest of all known anesthetics. The human VAC value is pretty high. Its low gas partition coefficient being so low, 63 to 71%, makes it suitable with using 30% oxygen. It has sufficient analgesia and hypnotic effects with 30% oxygen. The absence of metabolism, low toxicity, and is devoid of teratogenicity. Compared with other anesthetic regimens, xenon in anesthesia produces highest regional blood flow in the brain, liver, kidneys, and intestines, so dangers of tissue hypoxia are greatly reduced by its use. It appears to be an interesting alternative for anesthesia in transplant surgery. It may also protect neural cells against ischemic injury during cardiopulmonary bypass. It has neuroprotective effects that's been confirmed. So it might be one of the agents that we'll use selectively. Undisturbed ventilation, pulmonary function, and despite higher density, nitrous oxide does not alter the respiratory mechanics, and airway resistance is not increased with xenon at all. There's also lack of cardiovascular depression, the most appealing characteristic of xenon, even with 80% concentrations, calcium influx into the cardiac myocytes remains unaffected, so you're not going to get any contractility effects. Myocardial performance index, contractility, left ventricular systolic wall stress did not show any forms of depression. And diffusion hypoxia is less than nitrous oxide. Big limitations of xenon is its cost per hour. If you're looking at $170 an hour compared to SIVO or Desframe, which is around $60. It's also very difficult to produce, and there's really not enough xenon in our atmosphere as to be able to deliver enough anesthesia to everybody in the world if needed. So it's going to be used in certain select patients for certain circumstances be appropriate, but it's something that you're not going to use every day unless we find some way to obtain more xenon from another area. It's the bad thing also is it's difficult to use in the sense that you have the special equipment to not waste any gas. You have to have very tight closed systems like I showed you in the previous machine before. And if you want the agent to work properly, you've got to denaturate the patient completely before you start the agent. So the limitation. So these are the things that I expect you to know in your test. What are the variables that influence pharmacological effects of inhalation and anesthetics? You should be able to go through these and make sure that you know all the different causes of how that can affect your anesthetic delivery. CNS effects of inhalational anesthetics and necessary discussions. What you expect is that all the key points is that the effects of all-time anesthetics and cerebral blood flow, also their effects on ICP pressure, cerebral metabolic rate of oxygen consumption, EEG activity, and then how overall mental function and activity is affected by these agents. All volatile anesthetics does not cause long-term impairment or intellectual function or retrograde amnesia, so that's a good thing. So you should know pretty much that in patients that you're delivering volatile anesthetic and you're not causing irreversible brain damage to them. Volatile anesthetics do cause a decrease in cerebral metabolic rate of oxygen consumption, which is kind of good in the sense that it protects the brain by putting it to sleep, and the actual need is going down, even though the supply is going up many times. There is a decrease in cerebral function. There's increases in cerebral blood flow that you see in a dose-dependent manner in most of the agents that we use. So you get an uncoupling between cerebral metabolic rate of oxygen consumption and cerebral blood flow. The increase in cerebral blood flow may have deleterious effects in certain populations, as they may increase ICP pressures. It seems like isoflurane and sevoflurane maintain reactivity to CO2 better than most of the other agents. Desflurane maintains reactivity to CO2 up to about 1 MAC. And after that, about 1.5 MAC, the desflurane loses its reactivity, nearly abolishing autoregulation completely, which makes it a significant problematic agent in somebody who has possibly elevations in intracranial pressure. What I want you to look at this graph is an example of the different volatile anesthetics that we have presently in use. If you look at it carefully, all the agents increase cerebral blood flow that you're using. Okay, if you're using halothane, it has the most predictive increase in cerebral blood flow. As a consequence, will increase your intracranial pressure most rapidly, followed by nitrous oxide, when used by itself, will also cause some effects. The volatile anesthetics, if you look at them carefully, it causes direct vasodilation, and the nitrous oxide increases it by increasing sympathomimetic actions, which is increasing cardiac output as a consequence. Halothane is a direct cerebral vasodilator, even though it's a systemic vasoconstrictor. Enflurane is a little bit more potent in its increases in effect in cerebral blood flow in comparison to isoflurane, desflurane, or sevoflurane. Intracranial pressure is basically increase in ICP, but also increases in cerebral blood flow. Patients at greatest danger of this, of course, are the patients that have low cerebral compliance and patients with intracranial mass lesions. Protection against increases in ICP can be done by a hyperventilating patient, which drives a hypocapnia. So hyperventilation decreases the likelihood of inhalation, since it will actually increase the ICP. In hypocapnic patients with intracranial mass, this is halothane. It has to be hyperventilated prior to initiation, otherwise the ICP pressures will rise. The danger is if you use enflurane plus hyperventilation, which causes hypocapnia, will lead to an increased risk of developing seizure activities when using enflurane. That's increase in seizure activity will increase the cerebral metabolic rate of oxygen consumption, and it also increases CO2 production during the seizure process, and that will lead to an increase in ICP pressures to follow. Isoflurane, on the other hand, can be ameliorated, this effect, by hyperventilating as soon as the induction agent's cracked open. Desflurane should also be true as long as you stay at less than 0.8 MAC. There's no increase in ICP, but once you get above 1 MAC, you start seeing an increase in ICP above that level. So if desflurane is used at a low level, it's not a problem, but once you get above 1 MAC, you really are going to get yourself in your shoes with intracranial pressures with desflurane. The halothane is a combination of nitrous oxide, increased cerebral blood flow by 65%, and equal anesthetic potency. Enflurane and isoflurane have a reduced effect, but enflurane increases blood flow by 35%, and isoflurane is less than that. The issue with that is, though, enflurane can cause seizure activities in patients, which can be not protective of the brain. Sevo and desflurane are similar to isoflurane in terms of cerebral flow effects. Again, make sure that you understand the differences, which should be the better choice in most intracranial damaged individuals. If you look at cerebral metabolic rate of oxygen consumption, volatile anesthetics reduce cerebral metabolic rate of oxygen consumption, with isoflurane being much greater in comparison to halothane. And halothane isoflurane is very similar with Sevo and desflurane. Isoflurane reduces cerebral metabolic rate of oxygen consumption, which itself will reduce cerebral flow. The direct isoflurane-mediated cerebral blood flow increases are offset by the indirect isoflurane-mediated decreases caused by decrease in cerebral metabolic rate of oxygen consumption. So they offset each other and sort of balance each other out. On the other hand, if you're using enflurane reduces seizure-type discharges, which is significantly enhanced with hypocapnia. So what you'll see is if you give 1.5 MAC of enflurane plus hypocapnia, and then you auditorily stimulate somebody, the person will start developing immediate seizure activity with a resultant increase in cerebral metabolic rate of oxygen consumption and a 50% cerebral blood flow increase, which follows with it. you can imagine ICP pressures to be shooting upwards in that individual. What about CSF production? This is another reason why N4A is really not a good idea in any patient who has intracranial injuries, is that N4A increases the rate of production of CSF plus decreases actual absorption. Isoflurane, on the other hand, doesn't have any effect on increase in production, but it's helped by increasing CSF absorption. So in that sense, isoflurane is, again, protective of ICP pressures. Nitrous oxide has really no effect on the rate of production of CSF. If you look at anesthetic agents and volatile anesthetic agents and the EEG activity, as you begin to put the person to sleep, volatile anesthetics, as long as you're under 0.4 MAC, the person will usually have increased voltage and frequency on the EEG, which will still indicate that they're awake. As the person falls asleep and goes into a greater MAC value, you get a shift in voltage from posterior to the anterior portion of the brain. The cerebral metabolic rate of oxygen consumption begins to decrease, and amnesia develops at this stage. Once you reach a MAC level around 1, frequency on the EEG begins to decrease, and you may actually get maximum voltage on the EEG. What you'll see is eventually a burst of depression, which occurs in the EEG, which indicates to you that you're getting a little too deep, and you're almost getting into the isoelectric range. Once you get above 1.5 MAC on most of these values, you look at desferring, between 1.5 and 2 MAC, you get EEG silence. EEG silence occurs with isoflurane at higher values around 2 MAC, and halothane can be much higher, as much as 3.5 MAC. So electrical silence does not occur with N4A. It actually induces a similar EEG pattern as seen in seizures. So again, if you want to have somebody isoelectric, which is the right agent to use, basically don't use N4A. Isoflurane is a good choice, and so is desferring. Desferring, the downside to it, of course, is that you get too high a level with it. It starts increasing ICP pressures. This is what a burst of pressure looks like. You'll hear this told to you when you're doing EEG readings on somebody. This indicates that you're developing too much depth in anesthesia, unless you're trying to reach isoelectricity. One of the things that you'll see eventually is that you'll end up doing cases like doing large spinal cases where you'll be doing both potentials. The volatile anesthetics basically have dose-related decrease in amplitude and increase in latency. The reason that's being is it's affecting sodium channels, so it decreases the amplitude, the height of the wave, plus the distance or the time between initiation and signal becomes increase in duration, which is what we call latency. If you use nitrous oxide, it's okay up to 60%, as it maintains adequate evoked potentials. It may not be the case if the person has a lot of signal to noise ratio, and you add the nitrous oxide in that situation, you can actually make it worse, make the EEG reading useless, or essentially evoked potential useless. So sometimes you'll have to be asked to be back off on your nitrous oxide. If you look at your mental function, if you use isoflurane, 0.4 MAC prevents recall in response to verbal commands. Nitrous oxide may require up to 0.5 to 0.6 MAC to reach that to prevent recall. Not using nitrous oxide has been found to have an increased risk of awareness during anesthesia. So that's why it's a good idea to use this agent as well. Conclusion, volatile anesthetics is a choice for patients with cerebral ischemia. For patients who develop cerebral ischemia, still remains to be isoflurane at this point. Look at the cardiac effects of inhalation anesthetics. Circulatory effects is a dose-dependent effect that you'll see. Mechanism of action is that you'll see volatile anesthetics will either impair sodium channels or calcium channels, and these will lead to myocardial contractility issues, peripheral vascular smooth muscle tone effects, and as well as autonomic nervous system effects. The similarities between some agents can put in a slightly different classes. Isoflurane and desferring seem to act more like each other. Sevoflurane, on the other hand, acts in between isoflurane and halothane. So, in that sense, there's some things that are similar, some things that are different. If you look at mean arterial pressure, volatile anesthetics all decrease mean arterial pressure in a dose-dependent manner. The way halothane does it is it does it by decreasing contractility. Halothane tends to be much more effective at inhibiting voltage-gated calcium channels in comparison to fluorine, which seems to be attacking more the sodium channels. So halothane does it by decreasing myocardial contractility. So that would be altering your SVR, versus isoflurane is acting on the autonomic nervous system and depressing it. And as a consequence, iso-sevo and desferring decrease the SVR. Nitrous oxide, on the other hand, doesn't really affect those kind of channels at all. So you see no change to moderate increases in mean arterial pressure, as nitrous oxide can be a sympathomimetic. Adding nitrous oxide tends to help decrease the MAC of volatile anesthetics so you can maintain a better blood pressure. Sometimes you'll see that clinically people make the mistake of shutting the nitrous oxide off when the person's blood pressure drops because they're saying that's the cause. Actually what they're doing is just reducing the MAC value that they're delivering, and this kind of happens very fast because of the blood gas partition coefficient. But if you have to say which one is having the actual bad detrimental effects on the heart, and the answer is going to be the volatile anesthetic. So maybe you should really shut back your volatile anesthetic and then maintain your nitrous for good anesthesia. Heart rate. This is kind of important. I expect you to know these differences for the test. Halthane doesn't really change heart rate at all. Okay, so you're having a significant suppression of contractility by Halthane, but at the same time doesn't increase heart rate to increase loss in stroke volume from the loss of contractility. So as a consequence, the patient has a significant drop in cardiac output. If you look at isoflurane, and it increases heart rate pretty much linearly to the first MAC, and after that it slopes off and hits what's called a peak effect. So in essence, if you increase isoflurane up, you will get a maximum heart rate in the usually it's around 85 to 90, and it usually stays there. Versus desferrine, as you increase your MAC value, the heart rate will increase dramatically, especially if you get up, if you change the MAC value very quickly with desferrine, you can get a tachycardia and may develop in a patient. If you look at sevoflurane, on the other hand, sevoflurane has an inverted bell shape. As you increase the MAC to 1%, you can see a significant decrease in heart rate. And after 1% MAC, at 1 MAC value and above, which is of course 2, then that individual will start seeing an increase in heart rate once again. Now the reason I'm pointing this out to you is if you have a patient who has bradycardia, it might not be the best choice to use sevoflurane. It might be better to use desferrine or isoflurane. If you have somebody who has significant tachycardia, it might be a wise choice to use sevoflurane, as in the first MAC you see the heart rate will actually begin to fall. So, the different agents you have to consider for different things. Cardiac output and stroke volume. Halthane decreases cardiac output in dose-dependent fashion, but it doesn't affect the heart rate, which is bad, but it does decrease the stroke volume, and that significantly is going to drop your cardiac output. Isoflurane and desferrine minimally decrease cardiac output because you see an increase in heart rate with both these agents with a small decrease in stroke volume. So the actual loss in stroke volume usually is offset by the increase in heart rate. Sevoflurane, on the other hand, has a mild decrease in stroke volume, but it decreases in cardiac output at 1 to 1.5 MAC because of the decrease of cardiac output. And once you get above 1.5 MAC, then cardiac output actually rises again. Okay, but at that point, you'd be very deep in the individual, so just be a little cautious about doing it. Contractility effects, which one has the most contractility effects? In the end, it's going to be Halthane, followed by enflurane, then followed by the other 3 agents that have minimal contractility, which is your isoflurane, isoflurane, desferrine, and sevoflurane have minimal cardiac effects, contractility effects. Nitrous oxide itself increases cardiac output via sympathomimetic effects. So as long as the patient's got a normal sympathetic system, then nitrous oxide is actually pretty supportive of it. If you start having somebody who's chronically diseased, who already has significant sloped or decreased in autonomic function, what you'll see when you start that nitrous oxide agent is significant instability of autonomic nervous system, and you can get a drop in cardiac output as a consequence. The other thing we try to sometimes measure is right atrial pressures, which is CVP. It would indicate to you an increase in pulmonary vascular resistance. Nitrous oxide, as long as you're staying under the 50% mark, usually don't have a problem. But in some patients who have pulmonary hypertension or have elevations in PA pressures for some reason, you could possibly consider not using nitrous oxide, or at least limiting it to 50%. Halthane, isoflurane, and desferrine all increase CVP. And it's questionable if they're actually increasing PVR or not. It's unclear. One thing that is useful is a patient that has pulmonary hypertension, that you may want to consider sevoflurane, because it doesn't really change the CVP at all when applied to these individuals. So sevoflurane may be actually a good choice for patients with pulmonary hypertension. As for systemic vascular resistance, halothane does not decrease the SVR. Okay, it really adds to the myocardial depression because it has a fixed workload. If you look at isoflurane, desflurane, they all decrease SVR, and they decrease the myocardial workload as a consequence. Nitrous oxide does not usually change its SVR. Sometimes the sympathomimetic will have that effect, so depending on higher dosages. Isoflurane tends to cause increased vasodilation in the skeletal muscle, which is 4 times an increase in blood flow to that area. And that's important to understand because sometimes you'll see people are using the isoflurane a lot, and they're using neuromuscular blockers, but they get a rapid onset. And when other agents like desflurane, they shouldn't expect to see that. Sometimes you'll do is you get used to the fluorine, and when you give them muscle relaxant, it's already working and has 0 twitches. Versus if you use the same agent, same concentration to another patient that's receiving desflurane, you may have to wait 5 to 10 minutes before the peak effect really takes place. So this alteration in blood flow significantly impacts the onset velocity of the agent. You also increase in skeletal muscle mass. You might be actually wasted perfusion. Some people were concerned that maybe that'll cause some kind of lack of blood flow to the other organ systems, but that's really not been demonstrated so far. There's also increased cutaneous vasodilation, which increases heat loss when you use isoflurane. These are nice pictures here showing you an idea about what happens in different circumstances with these different agents. If you look at halothane, it's really a decrease in contractility. It's really the major effect. As a consequence, you see a decrease in stroke volume. If you look at sevoflurane, you see a decrease in afterload, followed by a decrease in contractility, which decreases your stroke volume. Isoflurane and desflurane look very similar in the sense that both drop your SVR. It has minimal effects on contractility, except for a slight decrease, because it doesn't seem to impair muscle as much. So, nitrous oxide is protective, maintains your SVR, usually increases your heart rate and increases your contractility just a little bit. Sometimes you get an increase in forward stroke volume. Nitrous oxide, though, the downside to it is if you go up at higher concentrations, it may drive you upwards to on the curve, increasing your afterload, increasing your workload, and unless your contractility is actually improving, which in this case it's showing to be, then you can get significant suppression of heart if you're not careful. As for cardiac dysrhythmias, when you mix halothane plus epinephrine plus an adult, it's a bad combination as you increase the sensitivity of the myocardium to develop something like VTAC or VFib. So lidocaine has been proven to be partially effective in depressing this. If you look at halothane and epinephrine in children, you don't see any effect at all, or minimal effect. Desflurane, isoflurane, sevoflurane, epi really don't have any bad effects. So it's really only the halothane you have to worry about. And accessory pathways are inhibited by isoflurane. These are things that when we're doing EP studies, electrophysiologic studies of the heart, you want to see the accessory pathway to show up. When you use isoflurane, it actually will protect you so you don't get into that rearrhythmia. So in that sense, it's kind of a good agent to use if you're worried about causing reentrant arrhythmia. But the agent that doesn't cause any effect in the heart is the sevoflurane. So one of the things that you may want to consider is if you're in different situations, if you have a patient who has accessory pathways who's going for an EP study, and it needs to be under general anesthesia, sevoflurane is the agent of choice. If on the other hand, the patient is having a disease process such as WPW, when you put them to sleep, and you don't want the accessory pathway to be as effective, then isoflurane would be a much better choice in comparison to sevo. Spontaneous versus mechanical ventilation. This is just an example of what happens when you put somebody under spontaneous breathing. It's black lines. If you put them under mechanical ventilation, you see a mild increase in SVR, slight decrease in contractility, and decrease in overall preload is the most significant factor. So this is a reduction in preload, an increase in SVR, and a decrease in cardiac output. Okay, so that's what you tend to see when you mechanically ventilate somebody. If you mechanically ventilate them plus give them hypocarbia because you're overdoing it, then you get systemic vasodilation, which causes your afterload to decrease in this individual. And that's what this red line here is showing for you. And it follows the same decrease in contractility because of the decrease in preload. So this alone can cause this very significant drop in cardiac output and also cause a significant hypotensive event. On the other hand, what causes elevations in CO2? Well, lap chole can often cause this because you're insufflating CO2 in the abdomen and the peritoneum is absorbing the CO2. A lot of times you'll see the person will develop hypertension during the case. The increase in CO2 causes peripheral vasoconstriction and cerebral vasodilation. You've seen this decrease the SVR effects by the volatile anesthetics, but the limitation on it is don't really let the CO2 climb if you're going to avoid it. In other words, don't decrease your minute ventilation in that situation until you're further along the surgery. Coronary blood flow, the book talks about coronary steel. It was a really big deal back in the 90s. I'm talking about this over and over again. Isophorin should be a coronary steel phenomenon, but it has not been found to be the case. Actually, what we found is that coronary circulation seems to be protected more so with isophorin than most of the other agents. So, desferrin and sevoflurane are also considered cardioprotective. Agent like propofol doesn't have any cardioprotective effects at all. So, final picture here is the possible mechanisms of the circulatory effects. Basically, you're looking at different reasons that have been brought up as to what are the possible causes of circulatory effects. Could be direct myocardial depression, inhibition of the central nervous system sympathetic outflow, peripheral autonomic ganglion blockade, attenuated carotid sinus reflexes, decreased formation of cyclic AMP or decreased release of catecholamines, or decreased influx of calcium ions through the stool channels. Either or any of these possibly can explain all the mechanisms that you see with volatile anesthetics. Okay. Last bit of lecture. Ventilation effects on inhaled anesthetics. Number one thing, all volatile anesthetics depress muscle function, at least ones that we have right now. So they also will cause a decrease in PaO2 response as well. So you lose a hypoxic ventilatory response when you put people under general anesthesia. Dose-dependent and drug-specific, what it does do for you is it increases your respiratory rate with all inhalational anesthetics. And isophorin has a ceiling effect around a MAC of greater than 1. You see a decrease in tidal volume and overall decrease in minute ventilation. As a consequence, you see an increase in PaCO2. You see a normally regular rhythmic breathing pattern you see with all the patients that develop anesthetics. What you see is the CO2 response curve is significantly diminished. If you look at the bottom picture to the right, it's using halothane as a primary agent. You see the curve initially, the patient who's consciously breathing and is awake. The normal CO2 is around 40, with a minute ventilation of around 6 liters per minute. As a person is put under deeper and deeper level of general anesthesia and their expired halothane concentration increases, their minute ventilation continues to drop and their CO2 response levels are higher, eventually reaching up to levels of CO2 of 60 to 80. So that's pretty impressive. Now, some of the agents actually, you get to a certain point, you get a certain MAC value, they'll actually stop breathing and won't respond to CO2 anymore, which is desferrin and sevoflurane can cause apnea around 1.52 MAC. Normal surgical stimulation can actually partially offset this. This is the picture on the left. These are patients who are receiving 70% nitrous and isoflurane. In the red, it's a person who is unstimulated. As soon as the incision is made, the person begins to breathe faster, and the actual CO2 values fall. So things that have been found to be helpful in supporting ventilation is nitrous oxide. It doesn't seem to increase the CO2 as much, so it causes less respiratory depression when combined with anesthetics. What you see here is the typical response. In this picture, we're showing you the agent desferrin without any nitrous oxide. As you're going up in the MAC, the value starts to show you that the amount of CO2 retained is higher and for the person to spontaneously breathe. Once you get above 1 MAC, you'll see that at 1.5 MAC, the person will be no longer breathing at all. So at 1.5 MAC desferrin, the person will not spontaneously breathe. versus if you use desferrine with nitrous oxide. See how the nitrous oxides actually help maintain that person's minute ventilation, and the CO2 is actually normalized to a more better number than with the agent itself. Sulforaine and halothane act very similar to desferrine in the sense that when you add nitrous oxide, it also will diminish the actual CO2 values for them to spontaneously breathe. What this means is that if you're having somebody that you're significantly depressing, you're either going to have to set the CO2 levels to be elevated, or you're going to mechanically diminish the patient. If you're going to assist the patient, that doesn't really work, because if you assist the patient and you start taking over the minute ventilation, you're going to blow off the CO2 and the person will go apneic anyways. So assisting ventilation is not something you really want to do if you want to let them spontaneously breathe. If you allow the person to breathe spontaneously, you will see an increase in CO2, this is an indicator of death. You must make sure that you have a plateau on your end-tidal CO2. So if you see a CO2 of 46 to 90, 50, you're not very deep. Actually, that person's pretty light. And once you get up in 50 to 55, just where the ideal level of anesthesia should be, right before surgical incision is made. And if you're getting above that and you're getting the CO2s up in 55, you're in a little bit too deep. The respiratory response to arterial hypoxemia is significantly suppressed with all volatile anesthetics, and that's really important to understand. That means as soon as you give that person a volatile anesthetic, and so if their main respiratory drive is due to hypoxic ventilatory drive, they're not going to breathe properly, and everything's going to go in a handbasket. Where you see that is patients that have bad Pickwinian disease or COPDers. Okay, so you also suppress the synergistic effects of hypoxemia, hypercarbia. If you look at airway resistance, there's an increase developing an intraoperative bronchospasm and certain things that will decrease your bronchiolar size, such as decreasing age. Perioperative respiratory tract infections, if you're putting in tracheal tube patients with COPD or severe asthma, and patients that are smokers. The most potent bronchodilator, and so I'm going to ask you a test question on, is sevoflurane, followed by halothane and then isoflurane, sorry. Desferrine, on the other hand, may cause bronchospasm in some select patients, especially smokers, and may be partially mutilated by fentanyl and morphine, and it doesn't seem to be that much of a difference with asthmatics. The cuff reflex is when you squeeze the cuff by the pilot bulb, may cause the person to start coughing and not breathing properly. It seems like that reflex response is best attenuated by sevoflurane. So sevoflurane really seems to be the best drug for increases in airway resistance. And the last slide is on mucociliary response. As you give somebody anesthesia, two things happen. One is you giving a drugging agent such as oxygen, and also the volatile anesthetics actually affects the cilia, so you get a decrease in mucociliary response, and decrease in inhibition, and increased risk of developing mucus plugs for these patients. Hopefully this has been an interesting section. We'll talk about next week on narcotics. Good luck on your test.